Now the other thing is, what flow meters do you guys see up on your floor, right? You guys are the most complicated flow meter floor in the world. And I swear I'm always digging into that small equipment budget all the time because you guys call and you're like, hey, where's that 3-liter flow meter? And I'm like, I have no idea. Right? So I'm gonna start passing a couple of these around. I have, this is a CC flow meter. It goes up to 200 cc's, okay? One for you. Stand by, I'm hoping I have enough. One for you. One for you. Okay. So the CC flow meter is going to go up to 200 cc's. Some of the old ones that still exist that are out there on the floor go up to 250 cc's. Sure, you can totally use that, right? If you're going to 200 cc's is like a fifth of a liter, okay? 250 cc's is a quarter of a liter. So this maxes out because this company was sort of like, look, if you need a quarter of a liter, then go to something like a 3-liter flow meter, right? Or I don't know where they are, somewhere in this hospital there's 1-liter flow meters, but just try to understand the calculations of what is 250 cc's, how does that relate to the flow meter that I have? Because I've got that call where somebody has called, right? And they're like, hey, I asked your RT for an 1/8 of a liter, and they came up here and set them up on 125 cc's. You need to talk to them, and they need to come up here and fix it, right? So of course I'm like, I'll be right up, and we will have that discussion, okay? So just understand those relationships, and then which flow meter you actually want to have, right, in the room. I know, sorry. So Ted is our student educator, and he had a class in here this morning. He and I had talked about like 2 months ago when Katie prepped me that I was going to do this class. So last night I set up the room for you guys. I made little workstations and did all this stuff. I put signs out that said don't touch anything, and I came in here early this morning and he had wiped the whole classroom out and was having a lab in here, so he was a little mad and I had to kick him out. I apologize. This room is sought after all the time. Okay. Are you guys feeling okay about the conversions as far as CC flow meters and all that stuff? So it is also taken into consideration, if I have to do a resuscitation, right? Do I only want a 200 cc flow meter in the room? Hell no. You will never get that little self-inflating bag. It'll re-inflate, but that reservoir that's supposed to hold 100% oxygen, that thing's just gonna stay collapsed on you all the time. That's gonna be a huge bummer. So if you look at this 3 cc flow meter, right, at the bottom it has that 1/8, right, 125 cc's down there. So if you need anything less than that, you're totally screwed. You gotta go to the cc flow meter or the 1-liter flow meter. I just don't know where to tell you to find them. Feel free to look at that.
Is there a general rule, like, I mean, I guess it's gonna depend on what their oxygen requirement is, but if we know that we have a patient coming in that's such and such age or such and such weight, we'll always have a 15 in there, but should we automatically start out with a 200 cc flow meter or go to the 3?
I do not know of a rule, and if you come across one, please like throw it at me. No, we just have to feel out exactly what it is. Because some of those cardiac kids, without getting too deep into this, right, some of those cardiac kids, when the doctor comes in, they're like, we just need a whiff, then we have to have that discussion. What do you consider a whiff? You know what I mean? Is it half of a liter, or is it, 50 cc's? So let's just say you guys are in the chart in Prism, right? And now you're going to oxygen therapy as you go down that chart, and everything has a unit of measurement in there, right? So our oxygen therapy is listed in there as liters per minute. So if I had somebody on 25 cc's, how would you guys think that you would chart that? 0.025. Yep, you got it. So this is a common mistake that happens all the time where I go up there and it's charted as, this is a true whiff, right? I can't go any lower than 25 cc's. Yes, there's a little gap on that cc flow meter, but it's actually not safe to go below that 25 cc's because if anything changes in the room, like barometric pressure, temperature, that little ball could drop and they could stop getting oxygen. So whatever the lowest written indicator is on that flow meter, don't go any lower. Cool? And if you need to go any lower, look for a different type of flow meter. But that 200 cc flow meter is the smallest one you're gonna get. So 50 cc's, 0.05, right? 500 cc's, we're on a half a liter. Maybe we just go to a bigger flow meter anyway, okay? What else do I have in here? I have another version of the 3-liter flow meter. It just has different markings on there. This one goes down to 1/8 of a liter at the bottom as well, so just be aware that that's there. Okay, 15-liter flow meters, right? This guy right here, set it up for all resuscitations, either whatever it is, an AMBU bag, a flow inflating bag, a neopuff if it's in transition. What's the difference between this guy and this guy? They're both 15 liters.
Oxygen, air.
You got it. You got it. And that's one of those things where I'm like, super simple, right? But then I walk up to, not you guys are actually doing pretty well. I'll go up to a different floor and they're like, I'm just cranking the oxygen and I can't get their sats to come up, and I walk into the room, yellow flow meter. Okay? Make sense? I just wanted to throw that out there. Don't be insulted that I did. I apologize. Okay, our last high flow device is going to be, what is it? Non-rebreather. Yeah, exactly. So this guy's simple. Crank out with your liter flow, whatever you got to get it to. Inflate this bag. You know, you can go too high on the liter flow where it's annoying everybody in the room because the noise is so loud. But once you get this going, I'm never going to give a recommendation on liter flow for this, okay? Once this is going, make sure no more than 1/3 of this bag collapses as they inhale. Does that kind of make sense? Okay. So fine tune it, find whatever it is. Don't hook it up to the yellow one because your sats are not going to come up. Sound good?
I have a question about the actual mask piece.
Yeah?
Explain the little white flaps, like, because you don't use that with the venti mask, but you do use that with the non-rebreather.
Yep, you got it. So this guy, right, we don't want to allow any more unnecessary air entrainment in here than we need to, but we still have to be able to exhale out these little ports right here, otherwise we would rebreathe CO2. So this one seems to be compensated for by having those two little ports that are in there. Most of that flow is just going to come straight up through here, straight to their mouth or nose, whatever it is, and then they'll be able to exhale back out of here to eliminate CO2. Okay, this one is very dialed in. One side has the little one-way valve, one side doesn't. That allows the right amount of CO2 to be exhaled, where at the same time keeping that 100% oxygen going to the patient. Can you guys see it on the mask right there?
I guess that's why I never quite understood, like, how can the venti mask be so accurate? Because I always feel like they just also inhale through the holes, but the pressure is high enough that they always get
The
that
flow
set.
is high enough.
Okay.
Yep. That's why those flow rate recommendations right there are compensating for that exact idea,
Okay.
right? But they come up to you and they're like, hey, can you go put that kid on a 4-liter nasal cannula? You guys should actually start thinking, is that appropriate or is that too much flow, right? So if you remember in the beginning, I was saying, if you exceed a patient's inspiratory demand or their minute ventilation, then you just put them on high flow. The downside to that is now that 100% is coming at them, right? They're not entraining air from anywhere else because it's just coming through that little nasal cannula. With high flow, you are now washing out that upper airway so they don't rebreathe CO2, congratulations. But what sucks is that you are now cooling them down and drying out their nose, and you are backdooring this style high flow nasal cannula, which is heated and humidified, in which case you could be providing some type of distending pressure. So yes, at first you're like, nailed it, this person's satting well, their work breathing looks really good, and then suddenly I get that phone call a couple hours later that's like, my secretions just clogged off, right? And they cannot pull anything through their nose whatsoever. So, this is tough. It's kind of like a little arbitrary calculation, but it'll get you there, right? Minute ventilation is a combination of tidal volume times respiratory rate. When you exceed their minute ventilation, you just exceeded their inspiratory demand. You put them on high flow nasal cannula, and remember this moment, because now I'm gonna come upstairs super heated, right? And we're gonna have a talk with that resident, we're gonna set up this pole, and at this point, if they don't have bronchiolitis, you just all did the wrong thing, right? So, To figure out somebody's tidal volume, we're not gonna intubate them and put them on a ventilator, right? That would totally suck. Just for this one time, figure that their tidal volume is 10 times their weight in kilos, okay? So if we're gonna do this calculation, up here I think I'm using a 3 kilo, yep, a 3 kilo kid, their tidal volume would be 10 mLs per kilo, right? So in this calculation, we have 0.03. You would multiply that times their respiratory rate. I'm just using 60 as an example here. So anything over 1.8 liters per minute for this child, you're exceeding their inspiratory demand. And congrats, you just put them on high flow nasal cannula. Give it a couple hours. They're gonna hate you, right? They might clamp down against it. They're actively cooling down. The problem is, some of these NICU grads that you guys are gonna get, right? We did a good job, we kicked them out of the NICU, we think that our job is done, but then you guys see them when they come in like a week later, right? They're not up to their full growth potential. Initially, what's gonna happen is, they're gonna burn into those fat stores, right? And their glucose is gonna go through the roof initially, and then eventually it's just gonna come right back down because now they're breathing super fast, they used up all their fat stores. Next thing you know, you guys are like checking their glucoses and you're like, this is all out of whack. Me as the RT, I'm like, that is not my problem, but it might have been because the resident just called me up and said, hey, put them on a 4-liter nasal cannula. And I'm like, okay, the resident told me to do that. I did that and that's completely the wrong idea, okay? So this gets you there. Of course, it changes because their respiratory rate can change, right? Me telling you to calculate their tidal volume at 10 per kilo is pretty high. It's super high. If I ever intubated a kid and went to go put them on a ventilator, I'm using like half that. I would figure out that their tidal volumes are about 5 per kilo, okay? You guys, does that sort of make sense to everybody? So it gets you close, but I just wanted the example to be there to give you an idea that in this case, this 3 kilo kid, you shouldn't be exceeding 1.8 liters, okay? All right, this is that venti mask that we were talking about. It goes from 24% all the way up to 50%. Feel right about it? The other devices, we have that oxy hood, we have the trach collar. Do you guys get a lot of trach collars that are out there? So we have this setup, sort of the high flow setup, where we can just adapt it into a trach collar if they need heat and humidity and something like that. We can go down that path later. This is the head box. This is one of those things that you are gonna see super rarely, right? Really, it is kind of one of those last resorts where we can think about, it's an oxygen-rich environment. I now have a baby that's this size and they're like, I'm not keeping that non-rebreather on my face, or even a nasal cannula. They're just gonna rip all that crap off, right? Otherwise, the rest of the hospital, not the rest of the hospital, the NICU, we use this for a nitrogen washout for a pneumothorax. I'm not gonna get too deep into that, okay? It's a little bit controversial.